Welcome to this educational video on breast cancer treatments. Breast cancer is the most common non-skin cancer in women and is a disease where treatment decisions are uniquely driven by molecular subtype. Unlike many other cancers where a one-size-fits-all approach to chemotherapy is used, breast cancer treatment is tailored based on three key receptor markers: estrogen receptor or ER, progesterone receptor or PR, and human epidermal growth factor receptor 2 or HER2. These markers divide breast cancer into distinct subtypes, each with its own treatment algorithm. In this video, we will review the major drug classes used in breast cancer, including endocrine therapy, HER2 targeted agents, CDK4/6 inhibitors, cytotoxic chemotherapy, immunotherapy, and PARP inhibitors. Before we begin, this video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Always refer to current clinical guidelines and institutional protocols when making treatment decisions. Let's start with how treatment is organized by breast cancer subtype. About 70% of breast cancers are ER positive and or PR positive, also called hormone receptor positive. These tumors rely on estrogen signaling for growth, so the backbone of therapy is endocrine or hormonal therapy, often combined with CDK4/6 inhibitors in higher risk or metastatic settings. About 20% of breast cancers overexpress HER2, a tyrosine kinase receptor that drives aggressive tumor growth. These patients receive anti-HER2 targeted therapies including monoclonal antibodies, antibody-drug conjugates, and tyrosine kinase inhibitors. About 10 to 15% of breast cancers are triple negative, meaning ER negative, PR negative, and HER2 negative. These aggressive tumors have historically relied on chemotherapy alone, but now immunotherapy with pembrolizumab and PARP inhibitors for BRCA-mutated tumors have expanded the options. Now let's discuss the mechanisms of endocrine therapy in detail. There are three main strategies to block estrogen signaling in breast cancer. First, selective estrogen receptor modulators, or SERMs, like Tamoxifen, directly bind to the estrogen receptor. Tamoxifen acts as an antagonist in breast tissue, blocking estrogen from stimulating cancer growth. However, it is a partial agonist in bone, where it helps prevent osteoporosis, and in the uterus, where it can unfortunately stimulate endometrial proliferation. This dual nature is important clinically. Tamoxifen can be used in both premenopausal and postmenopausal women, and is the standard for premenopausal women with low-risk ER-positive disease for 5 to 10 years. Fulvestrant is a selective estrogen receptor degrader, or SERD, that not only blocks but actively degrades the ER protein, making it effective in metastatic settings when tumors become resistant to other endocrine agents. Second, aromatase inhibitors, including anastrozole, letrozole, and exemestane, block the enzyme aromatase, which converts androgens to estrogens in peripheral tissues. Anastrozole and letrozole are reversible nonsteroidal inhibitors, while exemestane is an irreversible steroidal inactivator. As monotherapy, these are restricted to postmenopausal women because they do not suppress ovarian estrogen production. Third, ovarian suppression using GnRH agonists like goserelin or leuprolide achieves medical oophorectomy in premenopausal women, reducing estradiol to postmenopausal levels. These women can then be treated with an aromatase inhibitor or tamoxifen plus ovarian suppression. Let's look at the key endocrine and CDK4/6 agents in a drug comparison. Tamoxifen is the prototype SERM, usable across menopausal status, with the notable risks of venous thromboembolism and endometrial cancer. The aromatase inhibitors anastrozole, letrozole, and exemestane are modestly superior to tamoxifen in postmenopausal women based on multiple randomized trials, but cause arthralgias and accelerate bone loss. Fulvestrant is given as an intramuscular injection and is reserved for metastatic ER-positive disease. The CDK4/6 inhibitors represent a transformative addition to breast cancer therapy. These drugs, Palbociclib, ribociclib, and abemaciclib, inhibit cyclin-dependent kinases 4 and 6, which phosphorylate the retinoblastoma protein to allow cell cycle progression from G1 to S phase. By blocking this step, they arrest cancer cell proliferation. Palbociclib was the first approved and is used in the metastatic setting, Its main toxicity is neutropenia. Ribociclib is approved for both early and metastatic settings, but requires QTc monitoring due to risk of QT prolongation. Abemaciclib is unique in having adjuvant approval based on the monarchE trial, which showed significant improvement in invasive disease-free survival and, in its primary overall survival analysis, a 15.8% reduction in risk of death for high-risk, node-positive, HR+/HER2- early breast cancer. Abemaciclib is more CDK4 selective and its main adverse effect is diarrhea rather than neutropenia. If you're finding this helpful, please like and subscribe so you don't miss future videos. Now let's discuss HER2 targeted therapy. HER2, also known as ERBB2, is a receptor tyrosine kinase that is overexpressed or gene amplified in about 20% of breast cancers. When HER2 is overexpressed, it drives aggressive cell proliferation and is associated with a historically poor prognosis. However, the development of anti-HER2 therapies has dramatically improved outcomes for these patients. There are three categories of HER2 targeted agents. First, monoclonal antibodies. Trastuzumab binds domain 4 of HER2, blocking downstream signaling and mediating antibody-dependent cellular cytotoxicity, or ADCC. Pertuzumab binds domain 2 and prevents HER2 from dimerizing with other HER family members, including HER3. The combination of trastuzumab plus pertuzumab plus a taxane is the standard first-line regimen for metastatic HER2-positive breast cancer, based on the Cleopatra trial. Second, antibody-drug conjugates or ADCs deliver potent cytotoxic payloads directly to HER2-expressing cells. Trastuzumab emtansine, known as TDM1, is the standard for patients with residual invasive disease after neoadjuvant therapy based on the Catherine trial. Trastuzumab deruxtecan, or TDXD, is a newer ADC that has revolutionized treatment because it is active not only in HER2-positive disease, but also in HER2-low tumors, defined as immunohistochemistry 1+ or 2+, with negative FISH. This has fundamentally reclassified how we think about HER2 status. A key toxicity of TDXD is interstitial lung disease or pneumonitis, which requires close monitoring. Third, tyrosine kinase inhibitors including neratinib and tucatinib are small molecules that cross into the central nervous system and are valuable for patients with brain metastases. Neratinib is used as extended adjuvant therapy after completing trastuzumab. Let's review the cytotoxic chemotherapy regimens used in breast cancer. In the adjuvant and neoadjuvant settings, the backbone regimen is ACT, which consists of doxorubicin plus cyclophosphamide followed by a taxane, typically paclitaxel. Dose-dense scheduling every 2 weeks with growth factor support is preferred. For lower-risk patients or those who cannot tolerate anthracyclines, TC with docetaxel plus cyclophosphamide is an alternative. For HER2-positive tumors, the TCHP regimen adds carboplatin, trastuzumab, and pertuzumab to docetaxel. For triple-negative breast cancer, the KEYNOT 522 regimen adds pembrolizumab to carboplatin and paclitaxel followed by doxorubicin and cyclophosphamide in the neoadjuvant phase, achieving a pathologic complete response rate of 64.8% versus 51.2% with chemotherapy alone, along with significant event-free and overall survival benefits. In metastatic breast cancer, an important principle is that sequential single-agent chemotherapy is preferred over combination regimens because it produces equivalent overall survival with significantly less toxicity. Common agents used sequentially include capecitabine, taxanes, eribulin, vinorelbine, and gemcitabine. Platinum agents are particularly considered for triple-negative disease. Now let's cover immunotherapy and PARP inhibitors, two newer drug classes that have expanded our options for specific breast cancer subtypes. Pembrolizumab is an anti-PD-1 checkpoint inhibitor that has become a standard of care for early-stage triple-negative breast cancer. The landmark KEYNOT 522 trial demonstrated that adding pembrolizumab to neoadjuvant chemotherapy followed by adjuvant pembrolizumab significantly improved pathologic complete response, event-free survival, and overall survival. It is indicated for TNBC tumors 2 cm or larger or those with node-positive disease. In the metastatic setting, pembrolizumab is also used in combination with chemotherapy for PD-L1 positive TNBC. Key adverse effects are immune-related and include thyroiditis and other endocrinopathies, hepatitis, pneumonitis, and colitis. PARP inhibitors exploit the concept of synthetic lethality. In tumors with germline BRCA1 or BRCA2 mutations, cells already have impaired homologous recombination DNA repair. When you inhibit PARP, which handles single-strand break repair, these cells accumulate lethal DNA damage because they cannot repair it through either pathway. Olaparib is approved as adjuvant therapy for germline BRCA-mutated HER2-negative, high-risk breast cancer based on the Olympiad trial, which showed improved disease-free and overall survival. Talazoparib is another option for metastatic disease. Main adverse effects include myelosuppression, particularly anemia, fatigue, and nausea, with rare risk of myelodysplastic syndrome or acute myeloid leukemia. Let's discuss the adverse effects organized by drug class. Tamoxifen causes hot flashes, vaginal discharge, and menstrual irregularities, with serious risks of endometrial cancer and venous thromboembolism, especially in women over 50. Aromatase inhibitors cause arthralgias, myalgias, and hot flashes, with the serious concern of accelerated osteoporosis and fractures, requiring DEXA scan monitoring. CDK4/6 inhibitors cause neutropenia as their class effect, along with fatigue and nausea. Abemaciclib uniquely causes more diarrhea than neutropenia. Ribociclib requires QTc monitoring due to risk of Torsades de Pointes. Trastuzumab is generally well tolerated but carries the important risk of reduced left ventricular ejection fraction or cardiomyopathy, so echocardiograms should be monitored every 3 months during therapy, and treatment should be held if the LVEF drops more than 10 percentage points or falls below 50%. Trastuzumab deruxtecan causes nausea, fatigue, alopecia, and the critical toxicity of interstitial lung disease or pneumonitis, which can be fatal and requires vigilant monitoring. Anthracyclines like doxorubicin cause dose-dependent cardiotoxicity with a recommended lifetime maximum dose of approximately 450 mg per meter squared, along with myelosuppression and alopecia. Pembrolizumab causes immune-related adverse events including thyroiditis, hepatitis, pneumonitis, colitis, and adrenal insufficiency. Understanding contraindications and drug interactions is critical for safe prescribing of breast cancer therapies. Tamoxifen is contraindicated in pregnancy and in patients with a history of deep vein thrombosis or pulmonary embolism. A critically important drug interaction involves CYP2D6 inhibitors, such as fluoxetine and paroxetine, which reduce conversion of tamoxifen to its active metabolite endoxifen, significantly decreasing efficacy. Patients who need an antidepressant while on tamoxifen should use venlafaxine or citalopram instead. Tamoxifen also enhances the anticoagulant effect of warfarin. Aromatase inhibitors should not be used as monotherapy in premenopausal women because they do not suppress ovarian estrogen production and may paradoxically increase gonadotropin release. When used in premenopausal women, they must be combined with an LHRH agonist. Trastuzumab should not be given to patients with LVEF below 50%, and concurrent administration with anthracyclines should be avoided due to additive cardiotoxicity. The standard approach is to give anthracyclines first, then switch to trastuzumab. CDK4/6 inhibitors interact with strong CYP3A4 inhibitors like ketoconazole, which increase drug levels and may require dose reduction. Ribociclib should not be combined with other QTc prolonging drugs due to risk of Torsades de Pointes. Pembrolizumab is contraindicated in patients with active autoimmune disease requiring systemic immunosuppression. PARP inhibitors can worsen myelosuppression and carry a rare risk of MDS and AML, requiring regular CBC monitoring. Here are some key clinical pearls to remember. First, always check ER, PR, HER2, and Ki67 on every breast biopsy because treatment is entirely subtype driven. Second, tamoxifen is the only endocrine agent that can be used as monotherapy in premenopausal women. If an aromatase inhibitor is needed in a premenopausal patient, it must be combined with ovarian suppression. Third, monitor LVEF with echocardiography every 3 months on trastuzumab and hold the drug if LVEF drops more than 10 percentage points or falls below 50%. Fourth, CDK4/6 inhibitors combined with an aromatase inhibitor or fulvestrant is now the standard first-line treatment for metastatic ER-positive, HER2-negative breast cancer. Fifth, trastuzumab deruxtecan is active even in HER2-low tumors, defined as IHC1+ or 2+ with FISH negative, which is reclassifying what we previously called HER2-negative disease and expanding treatment options for many patients. Sixth, in metastatic breast cancer, sequential single-agent chemotherapy provides equivalent overall survival to combination chemotherapy with significantly less toxicity. Let's review the high-yield summary organized by subtype. For ER-positive, HER2-negative disease, the first-line treatment is endocrine therapy with a CDK4/6 inhibitor. The mechanism centers on blocking estrogen receptor signaling and estrogen synthesis. In the adjuvant setting, abemaciclib is approved for high-risk patients, and endocrine therapy is given for 5 to 10 years. Major adverse effects include VTE and endometrial cancer from tamoxifen, bone loss from aromatase inhibitors, and neutropenia from CDK4/6 inhibitors. Key trials include monarchE for adjuvant abemaciclib and the MONALEESA and PALOMA trials for metastatic CDK4/6 inhibitor use. For HER2-positive disease, first line is a taxane combined with trastuzumab and pertuzumab. The mechanism involves blocking HER2 receptor signaling and promoting antibody-dependent cellular cytotoxicity. For residual disease after neoadjuvant therapy, TDM1 is the standard. Major adverse effects include cardiomyopathy from trastuzumab and interstitial lung disease from TDXD. Key trials include Cleopatra, Destiny Breast, and Catherine. For triple-negative breast cancer, treatment is chemotherapy with or without pembrolizumab. The mechanism relies on DNA damage via cytotoxic drugs and immune checkpoint inhibition. Pembrolizumab was established by KEYNOTE 522, and olaparib for BRCA-positive patients was established by the olympiA trial. Monitoring includes thyroid function and liver enzymes for pembrolizumab and CBC for PARP inhibitors. Thanks for watching. Don't forget to like and subscribe for more medical education videos. The information in this presentation is based on Harrison's Principles of Internal Medicine 22nd edition, Chapter 84, along with landmark clinical trials including KEYNOTE 522, monarchE, Destiny Breast, Cleopatra, Catherine, and olympiA, as well as current ASCO and NCCN guidelines. Full citations are listed on this slide. Thank you for watching this educational video on breast cancer treatments. Remember to always consult current guidelines and use evidence-based practice when managing patients with breast cancer.